So today's topic of discussion is patient handoff. But before we go further, I would like to ask all of you if you have any questions from the last session. I hope you remember what we covered in the last session. Does anyone remember? It was how to design a program. The topic was how to design a program. So any afterthought or any questions about the session?
Facilitating skills.
Sorry?
Facilitating skills.
That will be covered in the next session, facilitation skills. So in this we covered how do you go about designing a program, because that was the foundation session. Like for example, how do you set your training needs, how do you do training assessment, how do you set your training objectives, what all you should know about your audience before you develop your content, because you always develop your content based on what your audience already know. From there you build on and then you take them to another level of knowledge, and many other aspects we covered, that how can you make your program impactful. Facilitation skills we will be covering in the maybe session 8. I think in session 8 we will be covering that. So that was about designing a program. And today's topic of discussion is patient handoff. So if maybe one or two of you can raise your hand and unmute your device and explain what exactly we mean by patient handoff. Raise your hand before you start speaking, so it'll be easy for us to see who wants to answer first. Okay, Dr. Purnima. Go ahead, ma'am. What do you want to share about?
Uh, at different levels of staff, there are different levels of handover. Basically, when in healthcare, there is shift-wise working, whether it is doctors, sisters, or even the support staff.
Mhm.
So it is very important that details from one shift to another are passed on accurately. The most important thing is at the end of the shift, staff is usually tired. There may be time constraints. So it is very important to regulate this. And it is very important that there should be complete and accurate handover so that continuity of care is maintained. And accurate continuity of care is maintained. And there should be no slip ups in patient care because of handover being inaccurate. That is the main thing which we can speak about handing over, though there is plenty much more, ma'am. Thank you for the opportunity to speak.
I just thought that let's lay the foundation by having some deeper understanding of any other additional point if somebody wants to raise. Yeah, Dr. Manjusha, go ahead, please.
Good evening, ma'am. Good
Very
evening.
good. Very good.
So, just adding on to what Purnima madam mentioned, even when you as soon as when you shift a patient from one patient care area to another, suppose the patient has attended your ER and you're shifting the patient to a ward or an ICU, even at each point there should be a handover. There should be a what you tell whatever, because for example you have started a medication from the ER which had to be stopped, but if the handover was not given, that would be continued, and probably a second medication with the same mechanism of action would be added from the ICU. So you will have to actually consolidate whatever is done at each point of care. That would include right from the point where the patient has the first contact with the healthcare worker to the point of time when the patient leaves the hospital, even after he leaves the hospital. And as ma'am rightly said, between each shift, between each worker, even for housekeeping staff, you would have to give this this routine of handing over is necessary. Everyone needs that, any healthcare work.
So as simple as that, for example, there's a leaking, tap in the bathroom, which could cause, somebody slip or fall. So housekeeping staff who is maintaining that area is supposed to not only report but also hand over to the next shift that there's a leaking tap, and we need to call somebody from maintenance and make sure that it is repaired. So even that's one kind of handover. It's not only about patients, but whatever task we are doing, and if that requires follow-up or some efforts by the other team member, so that's also, kind of handoff where you kind of pass on the responsibility to the next person. So anybody else who would like to, whatever Dr. Purnima or Dr. Manjusha has already covered, don't repeat the same, but if you have another perspective to it, it will be wonderful to listen from you. Okay, so what challenges do you often see? Because all of you, most of you are in hospital setup, so I'm sure you must be seeing a lot of lapses because of ineffective handover. So what challenges or what situations have you seen where improper handover has led to some complication or some discontinuity of care or patient safety being compromised? If anybody would like to share their experience without naming the hospital, without naming the doctor or the staff involved, just if you want to share the experience, what challenges have you seen or what situations have you seen? You can raise your hand, and if you want to. Okay. Dr. Manjusha, wait, I want somebody else to, otherwise I'll ask you to. Shovaji, I'm sure you must be knowing a lot of cases because you heading the nursing department in Care Hospital. So do you come across situation where improper handover between nurses has led to some kind of risk to the patients? Would you like to share any experience from this hospital or from any other hospital? Shobha, this question is for you. I hope you have understood me.
There are many incidences which led to some, I cannot say it's a sentinel event, but some event because of improper handover also.
Yeah.
So one example I would like to give regarding, there are so many, but I would like to specify this. So there was this particular patient in the evening who has been shifted from post-op area uh, to the ward. So post-op day 1, and patient was to break the whatever NBM was there, it has to be broken. And the doctor has given a written instructions that you can start with sips of water. So sips of water, evening night nurse has given, and the patient has developed some nausea because of anesthesia impacted on. So the nurse, doctor, DMO, whoever is available there, had told the nurse that I'll just confirm with the consultant. So went back to the consultant and accept whether to continue with the NBM or to stop, to keep it on hold, except that particular thing. Everything was written in the handing over sheet, documentation, that fluids to be continued, all that, but nothing of whether to continue NBM after few hours again sips of water should be given, or nothing of that sort. It was communicated orally to nurse. That was the DMO's statement. But nurse says nothing was told to me. Everything she has written in document. Until further, the next day, the doctor who comes for rounds at 10 o'clock, until then the patient was kept on NBM. So it was actually a hell sort of thing for the patient and the attender, where they came up for simple procedure and had to end up for more than 24 hours, only because of this. The consultant has clearly told them, let them wait for some more time, and after giving an antiemetics, they can give sips of fluids and they can start with some coconut water or tea, whatever the patient likes. That was not neither written nor communicated, but the doctor says that it has been communicated. If it was communicated, it should have been documented. That part was missing. That was one incident, and like this, so many other. Every day we come across, and a patient has unfortunately, satisfaction rate has gone down for the patient recovery, because though the IV fluids were running, the patient was feeling hungry and restless because of nobody communicated to them, though they were taking vitals and doing all that, but actual part no one was addressing. Though it was addressed by the consultant, it was not communicated to the patient and the nurse as well.
Very good. Thank you so much for sharing that. So a lot of time, food becomes secondary when it comes to patient care. I mean, we may talk about the medicines, injections, and whatever other care points we want to list down. We will put them in the, on the patient's case sheet. But food is something that we take very lightly. And I've seen it a lot of time, patients saying that I came at 1 o'clock, it's 5 o'clock, I have not been even asked, what do you want to have? Do you want to eat something? Have you had something? Patient is wondering that I can only eat hospital food because I'm supposed to be taking what the hospital provides, and I can't take anything from outside. And the staff is probably thinking the patient will take their food because that's not our responsibility till we are asked that either the patient has to be given this particular diet. So thank you for sharing that experience. I think that's very, very common. I think Dr. Manjusha, you wanted to share some incident. I think please go ahead. Yeah.
I'm very similar to this because I'm on the clinical side. We had a patient, an adolescent boy. So in pediatrics, we have this dictum of not using IV paracetamol. We prefer to use oral or rectal paracetamol. But on the other hand, the adult medicine, they prefer to use IV paracetamol. They used it on a day-to-day basis. So there was this intern of mine went to this patient, and the nurse was with her. She just told the nurse, in Malayalam, you put it as IV ittolu. IV ittolu means put the paracetamol ittolu. That means just put paracetamol. So the nurse thought, put paracetamol mane, you give IV paracetamol. In fact, she meant that the nurse should go back and look at the dose, whatever is written in the case sheet, and start. Actually, this particular patient received twice the dose he had to receive, that to an IV medication. And we got to know it only when the nursing staff called the PG concerned and asked us to document it in the case sheet. You're telling that your intern had told me to give a dose and you have not documented it. That is when we understood that the wrong dose was given or the wrong patient.
Right. Yeah.
Many such instances, because of lack of documentation, the second dose of insulin leading to hypoglycemia in patient.
Yeah.
Even not changing the bed sheet in the duty room, because the housekeeping of the first shift thought it would be done by the second shift. Second shift thought it was already done by the first shift.
Yeah. A lot of time that confusion happens. Very true. Very true. So any other incident, if somebody wants to share from their hospital or whatever they have seen in past? Okay. So what I'm going to share with all of you is a little more serious. What we have discussed till now probably was something which was manageable and you could handle the situation. But I have heard a lot of such, incidents from the participants who have shared that it has actually led to serious complication and even the death of patient or one of the mother of the child. Let me show you the slides and take you further from here. So this is one of the real life cases which was shared with me by one of the gynecologists from our hospital. This patient, I've changed the name. She was a known case of preeclampsia. She visits the hospital gynae emergency department. The resident on duty after examining her writes instruction on her chart, injection magnesium sulfate stat, and shift the patient to labor room. The junior resident promptly administered the magnesium sulfate injection and transferred the patient to the labor room. However, this drug has been given was not documented in the patient case sheet. And I'm sure this you must be seeing a lot of time when the patient is moved from emergency department to any other department. Whatever is done properly, but then not documented. So in her case, unfortunately, the same thing happened. The resident in the labor room did not know about it, so she gave the repeat dose of the same medicine. This led to patient experiencing respiratory distress, and she needed ICU admission. After a lot of struggle, they were able to save the mother, but we lost the baby. So I'm sure you must have witnessed something like this in your hospital. This is another case. Again, I know about this case. This patient was admitted in the hospital with acute MI. After settling him down, he was actually moved to the CCU after being stabilized. So meanwhile, the shift changed. Patient expressed desire to go to the toilet. His wife went and asked the nurse, "Can I take the patient to the toilet?" Nurse did not know that this patient had this condition because proper handover had not happened. So, and in a very casual way, she says, "You can take him." He went to the toilet and collapsed. The nurse later stated that she didn't know that he was a case of acute MI. And he appeared to be fine. Again, a life lost. Third case, another patient, she delivered a normal, healthy boy. She was actually wife of a hospital employee, the same hospital. Her husband was working in the same hospital. Now, this patient was shifted to ward after delivery. After a while, she felt that she's probably bleeding more than normal. So she asked her mother-in-law to go and report it to the doctor or the nurse on duty. So again, it was around 8 o'clock in the evening, coinciding with the shift change. So the staff on duty was preoccupied with the transition, and they said, "Okay, let the next staff come in and we will ask her to go and see you." But however, in the rush, they forgot to relay the message to the next shift staff. But for almost like waiting for an hour, the patient's mother-in-law went again to, inform the staff who had just come. But before actually anybody could seriously attend to the patient, this patient went into postpartum hemorrhage. And despite all efforts to revive, she could not be saved. Again, a life lost. What do you think were the reasons for these lapses? Communication gap and see, simple communication about the patient, whether it is verbal or written, plays such vital role in continuity of care and patient safety. In all cases, it was communication failure, effective communication, effective handoff. And this is nothing new. This is nothing that is rare. It happens very, very often, like no proper documentation or misunderstanding. So in healthcare, lack of seriousness, again, I think that's an important thing, misunderstanding, not responding in time, yes, agreed, and then lack of protocol. So lack of correct communication between staff, absolutely, and then no system in place. There are systems, Dr. Purnima. I think most of the time there are systems, but they are not followed meticulously. They are not followed meticulously. So when I ask nurses, how do you hand over? A lot of time they will say, "Ma'am, we go bed to bed to hand over." Okay. Suppose if the next staff is late, uh, how do you hand over? Ma'am, then we hand over in the changing room. We change our clothes and also hand over. Okay, the next staff comes further late, then how do you hand over? Then we hand over while at the nurse's station, and then we push on. What if the next staff comes further late? I then just say, "I've written everything, you can read it, and if you don't understand anything, you can call me." This is one line handover. I was taking a session for a group of residents working in critical care medicine. So I asked them, "How do you hand over in your, critical care area, ICU, etc.?" So one of them said, we say, "ये दो को देख लेना, बाकी सब ठीक." I can see many of you are smiling. So you know this is what exactly our handoff is. Am I right or wrong? Exactly. So one of my relatives was admitted in one of the very premier institute. He was operated for ruptured appendix, and he developed a lot of complications also. Incidentally, in between, the surgeon who had operated him, he had to go for some foreign trip. It could be some conference or whatever it was. I am not concerned about that. But he handed over the case to another colleague. Trust me, the next colleague who took over the case didn't even know ABC of this patient. As a result, this patient suffered so much that they literally had to move the patient to another hospital because it was something like the doctor who was treating was away and the doctor who took over didn't know anything. And he did not even try to find out of course, all this could be, collected and could be found out and could be meticulously worked on. But nobody took the pain of doing that. Nobody made an effort to do that. But what about the patient who spent lakhs and lakhs of rupees and then also lost his health and suffered at our end? I think patient handoff is one of the biggest challenge in healthcare. It's one of the biggest challenge, and we have yet not been able to, find a solution to the problem. People don't take it seriously. There is no commitment. Uh, People don't come on time to take over. There has to be an overlapping time between two shifts for the proper handling. I don't know how many of your hospitals actually have that protocol where the shift who is going out and the shift who comes in will be together for at least for an hour. And if you have that system, I'm sure you must be, taking over and handing over properly. But in most of the hospitals, and especially in government setup, honestly, I have not seen anything like this. Dr. Purnima, do you have something like this in your hospital? You were nodding, so I think you have that system.
Ma'am, it is mandatory that there should be a shift overlap so that there is proper communication without the constraints of time, especially in metro cities where travel and other conditions can sometimes cause personal urgency. So, overlapping of time and handing over time, which is very, very important, and use of different, later on, we'll discuss that, I'm sure. But the thing is that handing over is one of the most critical elements of good patient care.
Absolutely. Thank you. So, Dr. Santosh, do you have that system where two shift, they have an overlapping time? Please unmute your device. Dr. Santosh, kindly unmute your device.
Yes, ma'am, we have the overlap in the shift, but still I still think some of the times it might happen that despite that some staff comes late and then
Exactly. So that means even if you have that system where you plan that there should be some overlapping time, how far it is followed meticulously? How many have taken it seriously and then put it in place and they come on time? Shobaji, do we have that in care hospital, that system of overlapping? So
No,
how do you,
ma'am, we don't have that overlapping.
but then how do you make sure that everybody hands over and takes over meticulously or properly?
So for them, the minimum required time is 30 minutes, ma'am, 2:30. Means if it is afternoon shift between 2 to 2:30, that will happen. And night shift, it is 8 to 8:30 and morning also 8 to 8:30. And we have supervisors and floor managers who will be overseeing during the daytime. But night it is again, we are left on them. Only in daycare areas, we have this overlapping system where we have no issues there. So the general shift of morning will stay from 8 to 5 and evening will stay from 11 to 8. So there is no issue.
So there's already a,
Yes,
and
yes.
what happened. So Dr. Nirankar, I'll come to you, Dr. Manjusha. Give me 1 second. So Dr. Nirankar, in your setup, between doctors, how is the handover and takeover done?
So we usually we have done duty hours in a way that 1 hour should be available with the doctors or while exchanging the duty, like morning 7 o'clock if duty is starting, then night people will go at 8 o'clock. And same with the nurses also, so that they can do a hurdle with about the overnight issues or the shift timing change whenever, like in the daytime, and both nurses and doctors are on the same page while taking handover.
And it is being followed meticulously.
We have implemented these since last 2 months. Initially, there was issues with taking handover and everything, but now they have streamlined everything and they agreed, both nurses and doctor, that they will take in a similar manner, and nurse and doctor both will be available at the bedside where the handover is going on. So if anything is missed by doctor or nurse, any one of them can address that this is the point important which we have to take care about.
I think that's a very good idea. I mean, having both doctors and nurses together about a patient, this thing, I think that's another good additional point. Thank you. Dr. Manjusha, you wanted to add something. Please go ahead. Yeah.
Madam, it's just a concern I had. We also have this, though these shifts are not overlapping, they spend at least half an hour, not at bedside, but still they spend half an hour discussing what happened and giving handovers. But what usually happens, especially in the wards, during this half an hour, patient care is a problem. If something goes wrong, either no one attends to the patient or it's the other way around. The handover does not take place properly. So, because we have a system where beds are not allotted in a strict basis, especially in the wards. In ICUs, there is a bed allotment to each nursing staff. But when it does not happen that way, and you have 2 nursing staff for almost 30, 40 patients, which is not the ideal the nurse-patient ratio. This is what happens. During that handover period, either the handover happens or patient care lags. So I don't know how the other hospitals go about, especially when you have a shortage of nursing staff.
I think that's a very important point that you have brought up, and I'm sure this must be a real challenge. So then, how are you managing? What actually is happening as a result of this?
When it happens usually in the evening shifts, when there are no much doctors around, not many doctors around, not many nursing staff. So if we are there, we give, obviously, as clinicians, we give preference to patients. But then we know that without a proper handover, things don't happen because our patients are not ready to wait. Especially, we have already told the patients, if you have a fever, you should get it recorded by the nurse stat. So they would be behind the nurse and obviously should be distracted during her handover time. That's always a dilemma.
I understand completely, yeah. But I think if
Dr. Manjusha, can I add something?
I just want to add,
Yeah.
I'll ask you something and then add to that.
So actually, ma'am, this is something handing over just to avoid the deviations during the handover. What one thing we have tried and we are still in process of that is shift outs and discharges to be happening before 5:30 or 6. So that nurses will not have any patients who they have to receive from the ICUs or anywhere. That deviation, that or what you call that busyness is not there in their mind. They are fully only for this. And from ER, we hold the shift outs or the transfers from ER to wards from 8 to 9 so that the nurses can leave off. And after that, again, the handing over, taking over happen. Shifting of patients from ER to ICUs and what's happened. So that 1 hour is a common understanding between the night MOD, night supervisor, and the night nurses.
So, Dr. Manjusha, I had a question for you. Are you following some protocol? Are you following some communication tool for handing over?
Actually, not, madam. No. As doctors, we do bedside handover. Usually, we have a 24-hour shift there. So in the morning, when the new MO comes in, most of the time, we do a bedside handover. But to be frank, many a times we have had people writing down. If we have got 30 patients in the ward, it's practically impossible. You need another hour, so the night MO will be tired. So what we do is we write down everything. Only, as you mentioned earlier, only the critical cases or cases which need attention will be discussed at length. Others, we would just note it down in a piece of paper and give it to them so that when they go for rounds, they know what all to look for and what all should be done. Apart from what is documented in the case sheet, I've made it a practice to have a couple of notes for the next MO so that he knows what is left and what is to be
Dr.
followed up.
Mandisha, if you bring in some kind of tool like SBAR, ISBAR, Dr. Niyankar has mentioned, SBAR, Mr. Anand has mentioned. So when you have a structured handing over, protocol, it really saves a lot of time. Because otherwise you may talk about the patient for maybe 5 minutes, but may not actually hand over the crucial information. But whenever you hand over the information in a proper format, it becomes not only easy but also very specific to communicate, and you will not miss any vital. We'll be discussing about that. And I'm not saying that implement SBAR or SBAR as it is. Customize it. I would say you can customize as per your setup, but make sure there is some structure that everybody knows. So what happens, even if the other person misses something, you will remember, okay, what is recommended for this patient, or what is your assessment about this patient? So what do you want me to do? So that means very clearly everybody knows that I have, like for example, in ISBAR, we know I need to know what is the situation now, what has been done in the last 7-8 hours, what is expected now, or what is recommended, or what is your assessment, or what is the plan of action. So I think that's how when you will start implementing something like this, you will see they will save a lot of time. Also, another good way is when we are handing over, for example, it is done only verbally. Why not the outgoing staff already creates a document where they mention what needs to be done? Of course, there can be some change in the plan, there can be some contingencies, except that for most of the patients, if it is 24/7 care, we know that this is what has happened and this is what is expected. So why not we write it down, and when we are talking and we hand over that or we go through the notes together, so it not only becomes easy, but the person who is telling knows I have to tell these things. The person who is receiving can clarify or can also read that this is what is expected from you. I mean, there can be many ways to actually systematically implement that. We'll be talking about in short. Parvi has raised her hand. So Parvi, go ahead. I think you have something to say or ask.
Yes, ma'am. In order to improve the patient handover process and make it more effective, two, three things can be incorporated. First is the electronic medical records that can really empower the hospital staff. Second is we can also have a coding system for patients who are extremely unwell. For example, a red code or a red chart, something that is visual, that whenever a nurse or somebody sees, they will immediately come to know that this patient needs extensive care. This can help in situations where the staff doesn't have enough time to go through each and every case sheet or medical records and immediately categorize patients into high risk patients and low risk patients.
I would agree and disagree both with you. I agree. By having that kind of color code, you are making sure that the patient who require attention are not missed by any chance. That's what is probably the benefit of it. But the risk is needs of other patients who appear to be fine or doing well. They may get compromised just because they are in that green category, and we assume that there is nothing much to be done for that. And the mind is very smart. I mean, I have brought that up in one of the slides. One of the cognitive process that interferes with effective handover is selective attention, selective forgetting, selective listening. And we have to be actually very careful about it, because when we are, like, for example, when you are handing over a patient to me and you say, this patient is fine, this patient is going tomorrow, is going to be discharged. So invariably, I would just assume nothing has to be done for this patient. What if this patient suddenly develops some drug reaction or some condition that wasn't there, but it's an emergency? There can be a huge risk of, lapses there. And so we have to be very careful about what we are saying. As I said, I agree and disagree both with you.
Yes, ma'am. I agree with you.
Yeah, ma'am. So I think you rightly said.
One second. Dr. Purnima has raised her hand. After her, is it okay if
yes.
Yeah, Dr. Purnima, go ahead, please.
I am taking up a little time, but I want to share with you all a personal system. It was not implemented from learning from somewhere, but it was self-implemented. That handing over personally, yes, the hospital the unit where I worked had an overlap system. Handing over was done bed to bed between sisters. But there's a system which I put in place. I won't say that I used EMR at that time, but when WhatsApp came, and that has been my signature move, which is even followed when I was in charge of the entire hospital. Every morning, the night person who is phasing out used to put in the number of admissions, the number of transfers, relevant information, which is standardized. And we all know that we don't need to type it out all again. If we have typed it, we can just copy, paste, and put in the relevant numbers. So, for example, how many admissions were there yesterday, how many transfers, how many births, how many were shifted out of NICU, that was all come in a WhatsApp message before the person of the night would phase out. It also helps the person who's in charge of the unit to wake up to that morning and see and issue the correct instructions, which can be, I'm not saying issue treatment instructions, but issue guidance levels, or at least know, you can get into that brain mode before you enter your place of work. Even when I was in charge of the hospital, this system was put in place, and every morning, everybody, whether they were on duty or coming in for the next shift or whatever, they used to know what has transpired the entire day. So there would be a physical handover, there would be time given for it, there would be system of overlap. We would not get in patients from another place of care during the time of handover. We would also avoid giving non-urgent treatment instructions to the sisters at that time. So we allowed a complete smooth handover between different levels of workers. At the same time, the people who were in charge got to know. So using any medium helps, because handover is one of the places where the maximum lapses can occur. Second thing is that even when transfer between units. Second thing is even the person in charge gets to know and can appropriately intervene, like I said. And third, it remains as a record so that we can refer to it and we can even derive statistics from it. Also, like someone mentioned, a physical printout which is attached to the treatment chart, in which the handing over basic things are written for the day. Thank you for the opportunity to speak.
Thank you, Dr. Purnima. I think that's more to do with how you really, hand over the complete unit, or at least update everybody about what is the existing workload. Of course, that's also part of the handoff. Thank you. Yes, Dr. Santosh, please go ahead. Yeah.
Yes. So I agree with you that the condition of the patient is quite dynamic. So while we might do a coding of the patient, but as you rightly said, sometimes the serious patient will become more serious, or
your voice is not very clear. Dr. Santosh, your voice is not very clear. Can you somehow arrange your mic in a manner so that we can
Are you audible now? Am I audible?
Slightly better. Let's hope that we are able to hear you. Go ahead, please. Yeah. Or maybe you can switch off your video, because maybe that will improve the quality. Yeah.
Yeah.
Yes. Yeah, go ahead, please. Dr. Santosh, we are not able to hear you. Are you there? I think he got disconnected. Yeah, that's okay. Okay, let him join once again. So, I think now we are getting fair idea that there are a lot of challenges around handoff. It's not all that easy. There are practical problems, and I think the way Dr. Purnima said, that leadership position plays a very big role in making sure that you are able to address those hurdles. You are able to see how those problems can be looked after. Like Shobhaji said, that we make sure that we don't hand over, or we don't take in any patient, or don't shift the patient from any one department to another during those hours when we are handing over, so that we can hand over in a smooth manner. So that means a lot of responsibility lies also on the administrators to make sure that the handing over happens properly, because there are genuine hurdles and genuine concerns that needs to be addressed. Okay, let me share the screen with you and take you through the slides. So we got to see time is one reason, workload can be another. Like Dr. Manjusha said, 2 nurses for 30, 40 patients. So obviously, and if you get busy with the handing over, then who will look after the patient's needs? So that can be challenge. Time can be a problem. Workload can be a problem. And there are many more things that we will be discussing about. We have talked about the lapses that you have seen. Studies have shown that transition of care is considered Bermuda Triangle of healthcare. So around 80% of the medical errors actually happen due to communication failure between healthcare providers during handing over process. Even Joint Commission has pointed to the same thing. Patient handoff communications have been identified as a critical safety and quality problem. So clearly shows, and honestly, we have yet not been able to resolve it. 50 years down the line, we are still almost there. We see a lot of lapses happening day in, day out under our care. 80% of the serious medical errors occur due to communication failure. Handover is the most common cause of malpractice claims in USA. In India, we haven't yet reached there, but we are not very far from something like this. And other risks are incomplete handover, which will lead to discontinuity of care. There can be wrong diagnosis and treatment, and wrong diagnosis and treatment. Ineffective handover can lead to wrong treatment, delay in treatment, severe adverse events, patient complaints, and of course, dissatisfaction, increased healthcare cost, and then increased length of stay. Lot of time you want a particular investigation to be done before the patient is discharged, but because we forgot to get that test done, so the patient has to stay further. Or a lot of time because of the mistakes or the errors done by us because of the poor handover can lead to patient harm and increase the healthcare cost and also increase the length of stay. And this is something we have seen very, very happen. So why do you think the effective handoff still remains a primary challenge in healthcare? Please write in the chat box. Why do you think it is still a challenge? It's been almost like decades and we know still we are not out of it. We are still struggling with the same challenge in spite of having, electronic managed record, EMR, and then verbal and written and communication tool. Okay. For me says it's high workload. Yes, that is one of the problem. But then for me, a lot of hospitals where the staff and patient ratio is as per the guidelines, still there is a challenge in proper handover. Then a strong likelihood of error due to human component. Yes, that's very true. We forget, we are busy, we are preoccupied, we are tired, we are upset, anything can interfere. Selective listening, selective attention, all that can definitely lead to problem. Then oral, that is face-to-face, creates more importance. So verbal is desirable because in verbal you have a scope to clarify, but only verbal is not helpful. And I will show you one study that says that if you're just verbally handing over, you're likely to forget almost 70 to 80% of what you have. So verbal handover is absolutely alone is not enough. Then overload and tired. Yes, that's one of the common problems. Time constraints, workload, ignorance regarding need for ignorance regarding need of handover is very, very relevant, Dr. Manjusha. Actually, we don't know the importance of handover. Once you will understand, once you will see the lapses happening because of poor handover, I think we become more responsible and more proactive in it. Incompetent because we have not been trained, we have not been sensitized, we do not have the tool, we are not facilitating that. If we are able to do that, I think we can bring a change. And then sometimes casual attitude. Absolutely, Poonam, I think that's one of the problem. We don't realize how this can end up into a major health issue. So some of the issues and dilemmas around patient handoff are like, for example, first of all, it is usually an unstructured one-way communication. Like Dr. Manjusha said that we are not following any protocol. I'm sure many hospitals are still not following any protocol, per se on regular basis. It's more like, okay, you are talking and the other person is listening. And especially, for example, if the person who is talking is junior and the person who has come in is senior, very likely the person who is senior will say, I know everything, you go. I know about this patient. So there is always a, impatience to listen. Okay. Then extreme variability and uniqueness of handoff and transitions in different areas. So for example, in ICU, it's very different. In CCU, it is very different. Maybe in a medical ward, it will be something very different. So there is an extreme variability, and each unit or each department or each specialty requires a very unique handoff format. And we haven't developed even a single simple format. I think the idea of having different formats for different setup will be another task for all of us. A lot of studies have shown that in a teaching hospital, there are around 4,000 handoffs happening every day. So it's a very high frequency kind of an activity. So obviously, once it is too much, then people also start taking it seriously. And then, as we have discussed, time commitment and process changes, are a challenge and they are required. Time is a problem, no doubt. Commitment, yes, because if I have to come 1 hour before my actual time, how many days will any staff be willing to come 1 hour before their actual time? And then it requires a process change. I mean, we all like to work the way we have been working. So even a smallest change is not, really welcome. So process change is not easy. And as a result, people are not very keen to bring change in their way of working. And then we still do not have any focused research on healthcare handoff. Not many studies have been done. I don't know if anybody has done in their hospital. Has anybody done anything like this in your hospital? Not very many. So I think knowing that handoff is a very important responsibility. It is transfer of professional responsibility and accountability. So when the patient experiences some harm in my duty, then I am accountable. I am responsible. So I have to remember that when I'm taking over a patient, then the patient's welfare and well-being becomes my responsibility. So handoff is transfer of professional responsibility and accountability of some or all aspects of care of a patient or a group of patients. And it is not a quick down and dirty exchange of few facts. People find it very boring, especially if it is verbal only. And if it is not structured, it can be very, very boring because some people like to give every small detail. Some people like to give very small detail. So you find it very, not only variable, but not really very to the point. But in this, both giver and receiver of the patient have important responsibilities to make sure that you take over the patient properly. And each party must be comfortable with the information exchange. There should be enough time and enough commitment and enough readiness to listen. So it's more like, shared mental picture. Person who is going off has attended the patient or set of patients in the last 7-8 hours, has to talk about them in brief, something like you're painting a picture for the person. So what has already happened, especially the important points. For example, if a patient has some drug sensitivity reaction or some patient's particular dose was missed or the medicine was not available or the patient had some episode, all that needs to be, communicated to the next person, provide all relevant information and then specific directions with rationale. So what needs to be done in the next hours? That needs to be communicated and with reason. Why? Keep this patient nil orally. But why? For what reason? So that you have to explain and you have to give the reason also. And then this is very important. This is where probably we mostly miss is check receiver's understanding. So you have said, has the other person really understood what exactly you were telling? So the receiver has to listen attentively, ask questions to clarify. Again, that's a very important point. You may not understand clearly. If you remember that Chinese whisper that we did in the first session, somebody who had read the slide mostly spoke to the point. But when the same information was passed on to the next person, the information was passed in the person's version, but there was no visual input. And as a result, whatever the patient or the person wanted to speak, they said it, but the person who was receiving the information did not ask any questions to clarify. And then use systems to remember important information. So maybe if you have a small, small notepad in your hand, if you're noting down simultaneously, okay, bed number 6 to be done this, bed number 7 to be done this. So there should be a system to remember important information. Lot of us rely on our memory. And I always say, mind is not for remembering. Mind is for thinking. So therefore, never rely on memory. Always write it down either in the handover register, or if you have some other way of noting down. But make sure that you note down. And a very important thing, that is read back. Whatever you have understood, if you just repeat it, this is what I understood. Is it right, or is there something else? And that's how you make sure that you have received all important information about the patient. So let's see at one of the cases. Sorry. Okay. This is one case where the boy is 14 years old. Kishore admitted 2 days ago with acute asthma triggered due to URI. So he's improving and is most likely going home tomorrow. So nothing much to be done. The patient is still on little oxygen. Just try to wean it so that he can actually go home. So looking at this case, what is your primary impression of the situation? What seems most important from the information? You can unmute and speak if you want. Anyone of you.
Patient is still requiring a little oxygen.
Okay, very nice. And
I wouldn't be happy with this handover because if a patient with asthma is on oxygen, it's not that he's going to go home tomorrow after weaning today.
okay. And
Nothing is
nothing much to be done. Most likely going home. So when you're taking over and you hear, oh, this patient is going tomorrow and nothing much to be done. So it's something like the person might say you everything, but you will only remember one thing. You can read this for yourself. So you are more likely going to notice what you are familiar with or what you are happy with. And in this handover, a lot of important things that we have not touched on, something like medication. What is the person receiving right now? Or in case, like the patient, if the patient had hypoxia, what was given now and what is the dose of the oxygen being given to them? Patient. And then infection, where does the patient stand in terms of infection? And then nutrition. And you see, nutrition usually takes the last position in whatever we discuss, because we assume that this is not a very important or relevant, whereas this is one of the important inputs in the patient's healthcare. And then what about the contingency plan? What in case if something changes? For example, if the patient needs more oxygen, so what do we do? Or for example, the patient turns febrile, then what is the plan of action? Or what, like we said, wean the oxygen as the goal is to discharge tomorrow. And for example, if the IV falls out and the patient is taking orally, so there's no need to replace. So the idea is the complete handover should cover all aspects of patient care, not just the medicines, but all other things. So a patient handoff should include patient's condition, care, treatment, medication, services, and any recent or anticipated changes to any of these. So where all have you seen handoff happening? What are the places where you have seen common handoff? You can write in the chat box.
Madam, I'm sorry to interrupt. Just
Please.
a doubt. Do you actually document the handover whatever we mentioned now in the case record of the patient, or because we nurses have a separate handover register which they maintain where they note down all such points, and that's not something that comes medico legally in the case sheet. So for any practical purposes, but what all you mentioned now are mostly doctor's orders, which we usually write in our case sheet. So where do you recommend we write the handover, in the case record or the EMR itself, and or have a separate register, which is just a handover register?
So I think it's
Unofficial.
all to do with the hospital policy. A lot of hospitals maintain a separate handover register because that makes it easy to remember for what patient what needs to be done, because you will be revisiting that register during the day to make sure that you have not missed any important action to be taken. I mean that automatically becomes part of the legal document because it's being handed over in a proper manner. Because handing over is not about the care that you are giving. This is the instruction for care. But in the patient's case sheet, whatever you're doing for the patient, that gets noticed, that gets documented. I would ask others to share their thoughts on the same. If anybody has a point to add to what Dr. Manjusha has asked. So Shobhaji, in your hospital, how are you managing? Are you maintaining a separate documentation register?
Ma'am, we follow this SBAR tool, which is a separate document, which is again the part of MRD file, that is patient file, which is. But whether it is to be added or considered as a legal document or not, that is a question thing, because any document which goes for legal or anything, they only look for nurses' progress notes and doctors' progress notes and medication chart, not the handover chart.
That's what I'm saying, that because that's for your internal,
Internal
communication.
thing, yes.
Yeah. And especially because see, if you will write in the
So we
patient.
had before is
Yeah, go ahead, please.
yeah. So before ISBAR tool, we had an elaborated handing over sheet, because every time we come across something, every consultant complain or every incident which happens or anything which reminds us to add one more point in the checklist, add one more. So it has become so elaborated that almost there were 90 to 100 checklists. It has really become a thick list. So they were actually not going through this. Then again, we had to come back to ISBAR chart, which actually is helping us. So we consolidated all that. So information, situation, background, assessment, and recommendation. That is a simple document and which actually helps the nurses.
I think ISBAR or SBAR also is okay, because every time you don't need to introduce yourself and the patient. ISBAR is helpful when you are calling somebody on urgent basis. We'll be talking about it. But SBAR is something which is being used, in most of the places, and it is found very, very, very helpful. Yeah. So coming to the common handoff, where all do you hand off? I wanted to know, where all have you seen actually handoff happening? Like
So you're asking me, ma'am?
Yeah, I'm asking everyone.
Okay.
The question is, where all have you seen, which are the areas where handoff actually happens? I'm not able to see any comments in the chat box. Okay, yes, now I can see. Ambulance seat 2 ED nurses. Yes, very right. In wards, ICU, post-operative, yes. Emergency room, ICU, wards, all patient care areas. OP, IP, interdepartmental, absolutely. Inpatient care, PROs, housekeeping, biomedical, food and beverages, facility, patient referral, yes. Between wards A and E, awesome. Between sanitation shift, yeah. So that means most common, I think, what we have always heard about handover is nurses shift change. We are so used to it. Then doctors shift change. Level of care, like many of you have mentioned, when the patient is moved from OT to ICU or from ICU to room, that also is a change in the level of care. Physicians transferring cares, that's like cross coverage from one specialty to another. Then patient being transferred in and out of the hospital. These are very common ones. Like some of you have mentioned about lab, blood bank, radiology. So they are also part of the handoff. On call is another kind of a handoff where you are sending a kind of a, calling the doctor or the specialist to visit. Then critical reports, especially in lab and imaging, where you want to inform the doctor on urgent basis that this is the finding, which is not in the normal range and it requires urgent attention. And that's also called handoff, where the team working in the labs or in the radiology department is supposed to inform in a structured manner to the concerned doctors. Then referral letters are also considered as one of the ways of handoff, where you are sending the patient to another specialist. Notes for second opinion is also part of the handoff. And then other transition in career, like you have already mentioned in your chat box, is ED, radiology, physical therapy. So these are very common ones we have seen day in, day out. Now, my next question to all of you is, what are the barriers to effective patient handoff? You have mentioned about time, you have mentioned about lack of training, but there are many more. For example, I'm not asking you again that question because I know we have talked about it. Time constraints you have already mentioned. Language can also be a challenge. Language can also be a problem when both the parties don't speak the same language. There can be handoff challenge between them. Volume of information can be a problem. Like Ms. Shova was mentioning about 90 to 100 points. If that's the volume of information you need to hand over about one patient, and if you have 20 patients, imagine how will you really be able to hand over that patient. And then complex systems, especially in critical care areas, there are a lot of things that you need to talk and explain. So that becomes challenging. Continuity gaps can be a problem. In one care area, something is being done. In the other care area, something is not being done. And there's a complete continuity gap. So that can also be a challenge to push effective handover. Then human fallibility. We can forget, we may be tired, we may be occupied, we may be upset, we could be overworked, it could be anything that could interfere with remembering and also doing that can become a challenge to effective handover. Confidentiality can be another barrier. A lot of time you know about a patient's information, but you're not sure whether I should pass this information to the next person or not. I mean, you assume that it is confidential information, so I'm not sure if I could be talking about it. Or a lot of time, you do not know about the patient's details, some confidential information. So you do not know what needs to be done in that case. So that can be a barrier to effective patient handoff. Cultural background can be another reason. Limitation of learning and training. I think this is one of the major areas because we have not trained our healthcare providers formally into handing over patients. I remember I was at one of the programs recently, I think last month. I asked doctors, and they were all doctors, medical officers in one of the district. I asked them to write a referral letter. I'm sure many of us cannot write that well because we have not learned. We haven't done. Writing patient's case sheet, writing patient discharge slip, writing seeking second opinion. We have not taught formally, so that actually interferes with properly communicating with the next team. Then negative impact of fatigue that we have discussed, differences in styles of communication. Now, some people like to speak only to the point. When they say only to the point, they may even miss something very vital. Some people like to talk a lot and give every small detail. So sometimes the person who is taking over may not really be interested in knowing all those details. So there can be difference in styles of communication. And as a result, the proper handoff might not take, especially when we are not following any proper tool, for example, SBAR or SBAR, there is a possibility that you can miss the information. Another common challenge that you will see, it could be between doctors and nurses. It could be between senior doctors and residents. And there we see a lot of time the team are not able to communicate effectively with their seniors, especially if there is a difference in hierarchy or there is a difference in the level of respect, level of empowerment. If you have not empowered your staff to talk to you or report to you any observation, they will never have the courage to speak to you and tell you that I think there is something wrong in this situation. So have you empowered your nurses? Have you empowered your team? Have you created that psychological safety where the staff can come up to you and tell you about their observation? It could be something which we missed, but do we really create that atmosphere where people can come and talk to you about those issues? Then, as I said, style of communication can be a challenge. Language can be a problem. Maybe you have a set of nurses who don't speak English very well, and if they feel that they can't come and communicate with you, or they can't come and tell you things the way they are expected to do, they will hesitate to come and share that information with you. Tone of voice can be a problem. If your tone of voice is aggressive, authoritative, intimidating, your staff will never have the courage to report to you their observation. Language, we have talked about, language can be a challenge. And then past experience can also be a challenge. For example, anytime in past, if you made fun of somebody or you shouted at somebody or you offended them publicly, next time they will never have the courage to report to you about what they have observed or what they have seen. So as I said, common cognitive process that also interferes with handoff is selective attention, selective listening, selective forgetting. So when you are handing over, you might think I have spoken everything, but the person may only pay attention to something very specific. For example, if you said this patient is getting discharged tomorrow, or this patient is doing okay. So all said and done, the person will remember only one thing, that this patient is going tomorrow because the patient is recovered and the patient is fine. Selective listening also, you will listen to what you want to hear. Rest of the things you might forget. And then selective forgetting, something that you don't want to do, something that you have not understood, something that you don't find making sense, you are likely to forget that. There's actually a YouTube video on it. How many of you have seen that video on seeing a gorilla in the activity? Have you seen it? Okay, let's see this video. Probably this will help us. So,
this is a test of selective attention. Count how many times the players wearing white pass the basketball. How many passes did you count? The correct answer is 15 passes. But did you see the gorilla? This video is from research by Daniel Simons and Christopher Chabris and is copyrighted. It is available for use.
So I hope you, how many of you could actually see the gorilla? Raise your hand. How many of you could see the gorilla? 1, 2, 3, 4, 5, 6. And how many have done this activity earlier? You have done it. So that if you have done the activity, you will definitely know. But you see, those who did for the first time, many of you could not see you didn't notice it, although it was there in the frame, because you were constantly focusing only on the persons wearing white dress and the number of balls you were counting. So selective attention, selective listening, selective forgetting, they're all, very usual, very common cognitive processes, and they greatly interfere with effective handoff, because you may miss very vital information just because you were just paying attention to one particular area or a particular thing. So industries like nuclear industry, aviation industries have been considered, high reliability organizations, because they use lot of checklists and lot of protocols to make sure that they don't miss anything. And if you remember, we discussed about a book called Checklist Manifesto by Atul Gawande. And again, that's all about because these industries use checklists extensively, so you are less likely to make mistakes. That is what is assumed. Now, if we actually implemented handoff in a proper manner, there's all possibility of reduction in medical error, and there will be reduction in preventable adverse events also. It will also improve communication without negative effect on the workflow. So that's the benefit if we start implementing handoff in a systematic manner. So this is one study done to see which method is the best one. They actually handed over 12 simulated patients in 5 consecutive handover cycles in 3 different styles. In the first one, it was just verbal handover. In the second one, only written handover. And in the third one, they used a standardized form with verbal handover. And it was found that when you just verbally hand over, there is loss of almost all the important data. When you just hand over in written, because I've seen in a lot of organizations, they just write in the notebook and assume that handover has actually happened. Especially, for example, when the patient is transferred from one care area to another. You have made your notes very clearly, like transfer notes, but will the other person who is receiving the patient go through all the notes? You must have seen our focus is only on the last instructions. What are the orders that needs to be fulfilled? Nobody goes through the patient's case sheet to know what challenges the patient had, why did the patient come in, what were the incidents that happened during their stay. So written communication is also incomplete, and it resulted in almost like 1/3 of the data. But when you hand over the patient using a standardized format and also verbally explain, there is a minimum loss of information. And that's what actually is considered one of the best ways to handle. So when you use standardized format, like we are talking about SBAR, SBAR, IPASS, button, there are many of them. When you use these kind of standardized formats, I think one thing is it is focusing on the patient and not on the provider, because you know that this is the set of information that has to be communicated. And the benefit is that everybody knows, all the parties, the person who is handing over, the person who is taking over, knows what is going to be communicated and how the communication is structured and what are the required elements. So automatically you will not miss anything which is very, important or pertinent. When you use these tools, you are actually making sure that there is continuity of care. For example, if there's a pressure sore or there's some drug reaction or the patient's sample has been sent for some investigation and the report has to be collected. So that means the continuity of care is maintained. It ensures patient safety. Then it also decreases the errors that can happen in patient care because of lapses. And then there is also decreased repetition. A lot of time, for example, you have given medicine, but you did not document it. There's a risk that the same medicine may be given again to the patient. So there is decreased repetition and there is increased patient satisfaction. So it brings a kind of more, structure in the way we communicate. So when we are talking about different tools of handoff, which all do you know? Write in the chat box. Let's see which all you know about. So Dr. Kausar, a lot of time you are, I think, leaving the session and joining in. Is everything okay?
Ma'am, the bandwidth is very low.
Oh, okay. Okay, that's all right. So I just wanted to know SBAR. Okay, Dr. Purnima has written SBAR. What other tools have you used or you are using or you know that you have heard of? Yeah. SBAR, I think most of the people. I think that's also one of the very common tools being used. So these are a couple of the tools that, but there are many more actually. 5Ps, SBAR, then they refined it to IPASS, then sign out and IPASS the method. So 5P is most, simple one, but the challenge with that is that it is not really helpful in many complex situations. So 5P is that first P is patient, second P is plan, third is purpose, fourth is problems, and fifth is precaution. So for an example, this is patient Ram, 54 years. Plan is to keep him empty stomach for barium meal. That's the purpose. Problem is that he is diabetic. And the precaution is please check his blood sugar every hour to avoid hypoglycemia. So if the action plan is very simple, then probably something like this can be very helpful. But in complex situations, this tool will not be of much help because there are many more things that will not fall in this 5Ps. Another one, which is again very common, is SBAR. It is introduction. I'll be briefly explaining this to everyone. Introduction, situation. SBAR is an acronym basically. Background, assessment, and recommendation. That means introduction, where you will give your introduction and introduction of the patient, and you will also take the introduction of the person with whom you are talking. For example, you are making a phone call. So first you will tell who am I talking. Then you will ask, am I talking to this person because you want to speak to a particular person? And then you will give introduction of the patient that I'm making this call for this patient. So this introduction is for all three parties. Situation is what is the current issue. We'll talk about all this briefly. And then you will give some background because that person is not physically present there or was not present there when that happened. So you need to give some background for that person to recollect what is this patient all about. And then assessment, like what do you think or what have you found? And then recommendation, that means what you recommend or you are asking the other person to recommend whatever they think is appropriate. So let's look at it in detail. I is introduction, that is identify yourself and your unit or what. For example, I'm Dr. So-and-so calling from ICU 2. So that means you have mentioned about your name. Or I am sister so-and-so and I'm calling from ICU 2. So that means you have identified yourself and place from where you're calling. The person can immediately recollect, okay, this is orthopedic ward, or this is medical ward, or this is pediatric ward. That's the reason why we should be giving our introduction. Then you tell about, I'm calling about this patient, where you tell the patient's name, bed number, and room number. For example, if it is not bed number, it could be room number. And then you check the identity of the person you are speaking to make sure that you don't narrate everything and then you realize, oh my goodness, this was not the person whom I had to talk. So I'm Dr. Revti from ICU. This is about patient Saroj, 58 years, on bed number 6 in ICU 2. And then am I speaking to Mr. May, Dr. May? So you are, before you actually divulge further information, you have taken introduction and you have given introduction. Second is S. That means, what is this situation? So situation could be anything. It could be change in the vitals. It could be change in mental status. It could be patient is unstable or has severe pain or bleeding, or you started blood transfusion, but the patient has some, chills and rigor. It could be some preoperative observation. For example, the patient has to go for surgery. You have checked BP and the BP is very high. So it could be anything. That means the present problem is something that you want to report. So when you say I'm calling because I have noticed change in the patient's sensorium, patient is not responding to verbal, call. So that means patient is, there's a change in the sensorium. Or it could be like I've received the lab reports and the patient's LFTs are very high. Or it could be I started the blood transfusion and the patient is complaining of chills and rigor. So idea is, what is the reason of call? Present problem is usually the reason for call, why you are calling the person. So in this case, background about the patient will help the person take appropriate decision or action. For example, if the patient is diabetic, hypertensive, has some allergies, some sensory impairment, or language problem, or anything that is related with that will help in making appropriate decision, will come in background. So this is the patient who was admitted with overdose of sleeping pills. So the person can immediately recollect, okay, we are talking about this patient. Or this is the patient who is admitted with enlarged liver. Again, with background, you are trying to help the person recollect more information about the patient. That's the whole idea. So this is the patient put up for surgery tomorrow. So this is about the background. Next is assessment. So assessment is, what have you, observed or assessed, or issues that you are concerned about. For example, it could be the vitals that are your concern. It could be sensorium. It could be severity of pain. It could be bleeding condition. So they are all very important and urgent situations requiring urgent intervention. So when you tell that the patient appears very confused, or the patient BP is very low or very high, or the patient seem to be in severe pain, so that means this is your assessment because you are closer to the patient. And you are kind of informing the other person about your assessment, what you have done. And then last one is R, that is recommendation, that or what you are requesting. For example, either what you think needs to be done. If you say the patient has a lot of pain, so shall I give him painkiller? Or when you say, can you please come and see the patient immediately? The patient is bleeding heavily, or patient has chills and rigor. Or you ask, should I discontinue the blood transfusion till you come back? So that means whatever you can do at your end, you are offering, and you're also requesting for something that the other person can recommend that needs to be done. So SBAR is being used, extensively in most of the hospital. But I think only challenge with this is when you are doing the same activity, for example, it is with nurses. So every time will you identify yourself, identify the patient, and identify the person whom we are talking to. That portion will maybe skipped. But yes, when you are talking about a patient to somebody who is not there in the physical setup, probably there SBAR is very, very good. Any questions about SBAR? Or any concerns you wish to raise? I think SBAR is being used extensively in most of the, and it's a very structured tool. You can always customize it as per your requirement. So I'm going to share one case study with you, one case with you, and I want you to, structure it in SBAR format. So let me show you the case study. So this is a case where you're asking for a neurology reference. I will not read it for you. I request all of you in your notebook, if you can write SBAR and just write what will go under I, what will go under S. First write in your notebook and then we can write in the chat box. Once you have done it, write done in the chat box. Once if somebody is ready. If you have been able to classify these in SBAR format. If anybody is ready, you can unmute and speak. Okay. Dr. Manjusha, just give me a minute. Let me see if anybody who has not participated till now. Aarti, would you like to speak if you have written? If you have,
Yes, ma'am, I have written, but there are so many like technical terms which I'm not aware of.
that's okay. That's perfectly all right. That's perfectly all right. Anybody else who would like to take this opportunity?
I can just try if I'm correct. So I is about about patient. So patient is Mr. Rajesh, 50 years old, and background is he has met with an accident, RTA, with multiple injuries. The assessment and the situation is that he has come to the emergency from ICU from emergency assessment. On we find that the multiple injury, no vital sign, no visible sign of external injury to the eye, but his condition is stable, but he's kind of sense of sensorium disorientation kind of thing. So the first impact is, of course, the emergency, whatever care, maybe IV line is given, it's not mentioned, so that will continue, but maybe his sensorium, maybe the sensorium has to be restored. So whatever is the cause, we'll do the diagnostics and see that if this is calcium, chlorine, the
So we are
potassium.
converting into SBAR, and you are the resident or the nurse on duty, and now you are calling for a specialist intervention. You are calling the neurologist. So assessment will be that he seems slightly confused.
Yes.
And a recommendation would be, please come as soon as possible to visit. Anybody else? Dr. Manjusha, you had also raised your hand if you would like to.
The introduction would be, I'm Dr. Manjusha, resident from the ICU. This is to discuss about Mr. Rajesh, a 50-year-old patient in bed number 3 in our ICU. And am I speaking to the neurology resident, Dr. So-and-so? And the situation would be, we have a patient who has come from the emergency department with diplopia and slight confusion. The background would be, he was involved in a road traffic accident with no grievous injury. Assessment would be, his vitals are stable, and he has minor external injuries only, but he appears confused. And my recommendation would be requesting the doctor to please come and see the patient as soon as possible.
Absolutely. So when you pass on this information in this structured manner, you have not missed anything. You have communicated everything relevant to the patient. Yes, Aarti, I think you want to say something. Go ahead.
Ma'am, I am having one question. When we are discussing about background information, like usually in referral letters, what we usually train to the students is that you're not supposed to talk about each and everything. Like the patient is admitted on so and so date, then we did this test, then we did this thing. Instead, you have to talk in very less words that this was the situation and now this is the problem which is there, and now means something that was the means we have to write in very brief. We don't have to discuss in detail. So
what happens if you remember that Chinese whisper activity that we did? That was a real life case.
yes,
And
ma'am.
in that, if you saw exactly this is what happened, when the information initially started, it was a complete information that this is a patient who was operated by Dr. Shetty for this reason. And Dr. Shetty has left for the day, and now the patient is complaining of numbness under the third and under the nipple area. Just because this information was not, shared in a complete manner, because everybody who was sharing whatever they thought was important was passed on to the next one. And if you saw the distortion of the message, ultimately the message did not reach in the right manner. It lost its purpose, and the neurologist came to see that patient after 16 hours on the next day. So when you are teaching and training this to your nurses, of course, irrelevant information should be cut down because you don't want to overload the discussion. But whatever is relevant, for example, this is a road traffic accident case. So immediately you realize, oh my goodness, there's a possibility of concussion or some, head injury or something. So that's the reason why whatever is relevant should be passed on. But when you do it in a structured manner, then you don't miss anything important. And you know what I have to speak after what. That's the whole idea. But if you leave it to the person to cut down the content, there is a possibility that the person might cut down an important part. For example, numbness. For somebody, numbness may not be something very serious. That's the reason we say that you have to, if you learn the structure. But like you said, we tell them to pass minimum information. They might miss something very vital related to it. That's the whole idea.
You got it, ma'am. Thank you.
Thank you. So, for example, this is what Dr. Manjusha said, and also Dr. Santosh also talked about. Hi, I'm Dr. So-and-so or Sister So-and-so from ICU. I would like you to come and see Mr. Rajesh. It can be little here and there, not that there's just one way of doing it. But the idea is that you're talking about a situation. When you have introduced yourself and you have checked their introduction, now you are giving them the situation. That this is the patient who is complaining of diplopia in the right eye. Background is that this patient is a road traffic accident case, shifted from emergency, and he has multiple injuries, but no apparent grievous injury. Assessment is his vitals are stable, but seems to be slightly confused. So that means you are mentioning that vitals are fine. And recommendation is, will you be able to see him at the earliest, or what would you like me to do in the mean? That's the whole idea. So another case, patient is again in the, just 1 second, I'm not able to read it completely. Yeah. I will not read it because of my throat problem. I request all of you to try your hands and convert this into SBAR. If anyone is ready with SBAR, you can unmute and share your work.
So again, if I'm
आप नहीं करेंगे, आप कर चुके हैं. Let somebody else try. Dr. Nirankar, would you like to try?
Yes, ma'am.
Please go ahead.
Hi, I'm Dr. Nirankar, and I want to inform about one patient. Patient name Mr. Raj, male, 29-year-old, admitted at Ward 2 today morning, and situation is that patient is having infection at the appendectomy site, wound infection at the appendectomy site. He was admitted for the same, and the situation is that after taking an injection of antibiotic, he developed a rash. So the background history, he's having a type 1 diabetes, and on assessment we found there is a rash on the body. And my recommendation is there is a drug reaction happen here. So could anyone from your unit can come and look after the patient? That is like, if I'm a nurse, then I can ask doctor to do the needful with this format.
Or to tell what needs to be done or to be given to the patient. Very good. Thank you. Anybody else who has not participated? Deepa ji, would you like to speak? Dr. Deepa, if you have done, if you are ready. I want everyone to try their hands, because this is something we have to learn and do it on regular basis. Yes, Dr. Deepa, go ahead.
I'll try.
Sure, no problem.
So introduction, myself Dr. Deepa. I have a patient, Mr. Raj, 29 years, male, in ward number 2. Situation, he's having skin rashes after antibiotic first dose. He's having rashes, red rashes all over the body. And background, he has type 1 diabetes. Assessment, he's anxious, red rashes seen all over the body, vitals are stable, temperature normal. So I would like to consult the dermatologist for the skin reaction problem. And the request is, I would like to consult the dermatologist for the patient. And the wife is very agitated, so I don't know where to pick that.
So did you say to call a dermatologist?
Yeah.
Okay. So usually if it's a drug reaction, I think even in the, like if it is a medical ward or a surgical ward, I think it is managed then and there itself rather than calling a dermatologist, or what it is. What do you say?
I think it's
if it is drug reaction, so usually it is managed in the same setup, isn't it?
Pardon?
It is managed in the same setup. That's right, because it's an emergency situation.
Okay.
With a reaction to the medicine. So you normally use the first line of treatment there.
Yeah,
Then
it seems to be a Steven Johnson syndrome. So maybe consultant has to treat.
yeah, sensitivity test. Aarti, you wanted to say something?
Yeah, ma'am. Shall I try?
Okay, go ahead.
Yeah. So this is Aarti from Ward 2. I just want to talk about Mr. Raj, who is 29 years old. Situation is he developed red rashes over his arms and chest after his first dose of antibiotics. Background is admitted this morning for appendectomy, wound infection. He is a type 1 diabetic. Assessment is he is vital stable, is temperature normal and likely allergic reaction. The recommendation is please review urgently for possible drug allergy and some antibiotic if needs to be changed.
Wonderful. So see, with little bit of trying, if we are able to, understand what will go under what head, I think after you try for a couple of times, you'll be definitely knowing what will go under ISBAR. That's the whole idea about the format. So just for everybody's understanding. So hi, I'm
Ma'am,
Sister.
one question.
Sure. Go ahead.
Ma'am, as I said that the patient admitted this morning, so this information is relevant or irrelevant? Like I heard most of the people who spoken before me, they have not talked about this one. Like, is it relevant or irrelevant?
See, again, it depends. For example, if this patient has been admitted and this is the first dose being given, so automatically it becomes relevant. If this patient was there with us and you have started some medicine, it depends again. I mean, there's no one line answer to it, but you would like to give as much information as possible so that the person can see the seriousness of the situation, can have the complete information that will help him to decide what needs to be done on urgent basis. So have we written somewhere that admitted for the first day one?
Yes,
Yeah.
ma'am.
He was admitted
It
this
is.
morning. Yeah. So that means it's a new case. It's a new patient. It's a new patient. And you're also mentioning that he's admitted today only for this appendectomy wound infection. He's type 1 diabetic. That means you are kind of giving some information about the patient for the other person to visualize. Maybe he is the consultant of the same patient. But if you have 10 patients under you, you will not remember every patient. So you would like to have some information coming in from the other end so that you can visualize, okay, this is about this particular. A lot of time the names are same, diagnoses are same. So it becomes very difficult to recollect which patient are we talking about, and there can be diagnostic error or a treatment error. So provide as much information as possible to make sure that the person knows which patient are we talking about.
Okay, ma'am.
Okay. So I think the idea of having this standardized format is to make the interaction or the communication very clear, crisp, to the point, save time, avoid repetition, avoid losing out on important information. So if you don't have that system still in place, there are a couple of things if you can remember and you can try in your workplace, you will be able to bring a change in the way things are happening. So to start with, I think most important is to identify all points where handoff occur. Like for example, we talked about only clinical handoff, and some of you mentioned about food and beverages or housekeeping. Even that's an area where proper handoff should happen so that the next staff knows what needs to be done. Then identify existing processes at all points. So if you just go and observe how right now the handoff is being done, just observe them and you will be able to identify the gaps. There are gaps in handoff. Then identify champions, physicians, nurses, and leadership. So when you will try to implement something new, not everybody will be happy to join in and try their hands. There will be very few people who will align with you, who will agree to work with you. They are the one who will take your implementation forward. So identify those people and then brainstorm with them to find the most suitable tool. So when you will discuss with them, you will try to identify what is the minimum communication that should happen from a person who is handing over to the person who is taking over. So you will find, you will be able to create some tool that suits you. So select a consistent approach to the handoff, develop a policy and procedure. Now you say that, okay, we will be trying this in one particular department just to try, or maybe you want to do it all across. It all depends on how you want to implement it. Educate staff. That's one thing. See, when you just ask them, you have to hand over like this, that's not enough. You'll have to really help them see why it is important. What lapses have you noticed? How it is impacting patients' recovery or outcome, and then how they need to upskill themselves. All that will become part of the getting your staff ready for it. Then implement the policy, monitor and report findings. So definitely once you will start implementing something new, there will be bottlenecks. There may be resistance, there may be time constraint, there may be overloading of work. Like for example, Ms. Shobha mentioned and Dr. Mansha mentioned that in one hospital, if you have 2 staff members and 40 patients to be transferred, so obviously you will have a lot of challenges. Or for example, if you have patient being handed over, and at the same time there are some transfer in and some transfer out, so naturally you are going to be distracted and overworked. So you'll have to see how you can reorganize those things and see this can be implemented in a serious manner. So monitor and modify the changes that you need to do and keep updating the tool. So implementation, once you will start in one place, then slowly you can try in other areas and you can see the benefit of proper implementation of handoff. So from here, going to the take-home points, please remember 80% of the errors happen because of the information loss, because of ineffective handling. So this should tell us the seriousness of the situation. It's one of the very important communication for continuity of care and patient safety. A lot of time patient safety gets compromised just because of poor handover. And then only written handover is not enough. Written communication should always be supplemented with verbal. Written is helpful, written is important, but it should be supplemented with verbal communication. Most important is handover is not given. Handover is always taken. Because the person who is taking the responsibility is now responsible for the next 8 to 10 hours. However, effective handover is the responsibility of both the parties. Both of them should take and give it seriously. While giving handoff, please be specific, concise, and deliver the information in a standardized format. Ask the receiver to repeat to confirm the important information. Once they will repeat it for you, you will know they have not missed anything important and they have understood exactly what you want them to learn from you. And then when someone is receiving information, listen attentively, summarize what you were told, and ask questions if needed. This is one thing we have to develop, as a habit, to ask questions. We just quietly take and we assume we have understood, but a lot of time we have not clearly understood the information. And then read back the most salient points of the sign off so that both the parties know what has been communicated. So this is in nutshell about handoff. It's a very detailed topic. There are a lot of activities and in the longer program, I make them write referral notes or second opinion notes. Are they able to really do it in a very structured manner? But I just thought that these two couple of case studies with SBAR tool will help us to see how we can communicate the same information in a more structured and crisp manner. So any questions about whatever we have discussed, or any input or any feedback if somebody wants to give? Yes, please.
There is one input, especially for the doctors in critical care when they are giving a handover to a night shift doctor, especially in the night. we emphasize them that we have counseled the so and so about the patient to same relative about the patient condition that has to be passed on to the next doctor who is going to be there over a night for a 12 hours. In case of anything bad happen or any requirement comes or relatives visit to ICU at night, then there should be a continuity of same counseling, same page, that he should pass on all the information which we have passed during the daytime. So that is also a part of, we consider that as a important part, that we inform the next doctor that we have counseled so and so thing to the patient relative. So patient could not be, that relative could not be surprised when the night doctor says something like which we have not conveyed to them.
In addition to what you have said, that's a very good practice. I think that's very important because it should be in the same line. It should not create conflict to the patient party or their family members and create confusion. The morning doctor was saying everything is fine, don't worry, and the night doctor says, oh my goodness, we are in a very bad situation. So it can be a very At the same time, if the handover is done in the presence of patient or the attendant, it's again a good idea because the patient, if the patient is conscious, should know that my doctor or my nurse is now, signing out and the next one has come in. So in case if they need some immediate assistance or some question to clarify or some information, they would clearly know that, okay, my so-and-so nurse is off and now the next doctor or next nurse. That's also very important. That's why we say handover at the bedside. So even like, for example, couple of things maybe that you want to talk about a patient, not in the presence of the patient and the family, can be done separately. But if you go bed to bed and hand over and tell them, okay, I'm off and now so and so will be attending to you, that's also a good way to let them know that there's a shift change and there's a new doctor or new nurse that is coming. That's also a good practice. But thank you for that. Any other input or question or feedback on this? So we have 16 of us. I think we have 16 of us, but very few have kept their camera on. Why so? I'm trying to pick up the feedback box. So I'm going to put it in the chat box. So Shovaji, you mentioned about PACE as one of the tools. Are you using this tool? PACE?
No, ma'am, not now. Previously, when I said we had one document which has got almost 90, components, and in that we had all PACE. As per that, we had this, but that did not work out for that for us. So we switched back
as simple as to the point, as simple as to the point as possible. Only then it will get implemented in real sense. Thank you. So I've shared the link in the chat box. I hope it's functioning. If you can check once. Yeah, it is. By the time all of you are doing this questionnaire, in case if next week's session needs to be preponed to Monday instead of Tuesday, is it suitable to all of you or no? You want it to be only on Tuesday? I'll put the poll in the WhatsApp group and I'll seek your vote on that. If you have done it, you can just write down in the chat box so that I can see how many of you have done it. I received 7 responses. 9. So some of you are keeping your camera off. I'm reminding you again, if you keep your camera off and if you're not visible, I tend to miss you and I forget to ask you. I try to engage everyone, but if you're not visible to me, I can miss you and I can forget that you are there. So I request all of you to make sure that you keep your cameras on. Only then the true interaction can happen. Some of you have already submitted your videos. Dr. Purnima, I think you can post your video in the group. You have done it.
Okay, ma'am. Thank you.
You can go ahead and I request all others to finish it. And if you have any challenge, do you want to talk now for a minute, or you can call me on my phone number tomorrow and we can discuss. But I request everyone to start working on it because we are just 4 sessions away from closing. And we have to complete this before we close the session, close the program.
I'm wishing you good health and early recovery from your minor complaints, and also wishing sir a speedy recovery.
Thank you so much. Thank you. Much needed at this moment. I didn't expect myself to fall ill. That was something that came as a shock. Seriously.
So, ma'am, that's very important because you are looking so dull.
I know. I'm thankful that I could conduct this session today because I didn't want to cancel at any cost. And that's why you must have seen my message coming late, very late today in the evening. Normally, in the morning itself, I send a reminder message. But I wasn't sure where I will be, in the evening. But thankfully, I'm doing well. I'm fine. Yeah.
Good salute to you, ma'am, and please take care of yourself.
Thank you so much. So if everybody is done, shall we close the session? Thank you. Thank you so much.